بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. إن شاء الله هنتكلم النهاردة عن different presentation of sodium disturbance. Is to establish the definition of hyponatremia and hypernatremia, review the clinical consequence of hyponatremia and hypernatremia, outline causes of hyponatremia and hypernatremia, approach to diagnosis of hyponatremia and hypernatremia, describe the treatment options to hyponatremia and hypernatremia. Let's begin with hyponatremia. Hyponatremia, the normal serum sodium level is 135 to 145 milliequivalent per liter. So hyponatremia is defined as serum sodium less than 135 milliequivalent per liter. Hyponatremia divided into three types: hypotonic or true hyponatremia with low plasma osmolality, isotonic or pseudo hyponatremia with normal plasma osmolality, hypertonic or translocational hyponatremia with high plasma osmolality. So what is meant by plasma osmolarity or osmolality? Osmolality means the number of particles per kilogram of solvent. It is measured by osmometer, and the normal plasma osmolality is 280 to 295 milliosmol per kg, while the osmolarity means the number of particles per liter of solution. So osmolality and osmolarity both measures and calculate osmotic activity. The osmolarity can be calculated by the following equations: 2 multiplied by sodium plus blood urea nitrogen divided into 2.8 plus blood glucose divided into 18. The difference between the two is the osmotic gap, which is normally less than 10 to 15 milliosmol. So let's discuss our cases. Case 1 is 70 years old female with no past medical history, presented with generalized weakness and fatigue. A diagnosis of multiple myeloma was eventually made. So it is an old patient with multiple myeloma presented with generalized weakness and fatigue. Her blood pressure is 115/70. Serum sodium is 127 milliequivalent per liter. Plasma osmolality is 28 milliosmol per kg. Total protein is 12 gram per deciliter. So let's look at serum sodium. It is 127 milliequivalent per liter, so it is a case of hyponatremia. To differentiate between true hyponatremia, pseudo hyponatremia, and translocational hyponatremia, we look at plasma osmolality. Here, plasma osmolality is 280 milliosmol per kg, so it is a normal plasma osmolality. So it is a case of hyponatremia with normal plasma osmolality, so it is a case of pseudo hyponatremia. It is a pseudo hyponatremia. Here the total protein is 12 gram per deciliter. There is a hyperparaproteinemia due to multiple myeloma. So pseudo hyponatremia has normal serum osmolality, occur in hyperlipidemia or hyperproteinemia as in our case, because lipid or protein occupies space in the volume of serum taken for analysis. The concentration of sodium in serum itself is not affected. So newer methods of measures serum electrolyte with ion selective electrolyte or overcome this problem. The second case is 90 years old male with past medical history of type 1 diabetes mellitus on insulin therapy, presented with fatigue, abdominal pain, and polyuria in addition of anion gap metabolic acidosis. So he was diagnosed as having diabetic ketoacidosis. Serum sodium is 123 milliequivalent per liter. Plasma osmolality 302 milliosmol per kg. Blood glucose is 1200 milligram per deciliter. What is the most likely diagnosis? Here is a young age male with diabetic ketoacidosis let's look at serum sodium. Serum sodium is 123 milliequivalent per liter, so he has hyponatremia. To differentiate, it is a pseudo hyponatremia or translocational hyponatremia or true hyponatremia. We should look at plasma osmolality. Here, plasma osmolality is 302 millismol per kg. So this patient has hyponatremia with high osmolality, so he has translocational hyponatremia. So the cause here of hyponatremia caused by plasma sodium dilution induced by intracellular water shift driven by the effect of glucose-induced increase in plasma osmolality. And so the treatment with insulin should correct this condition. So this is a case of translocational hyponatremia. Translocational hyponatremia occur in severe hyperglycemia or exogenous administered mannitol or glycerol, increases osmolality and water move out of cell into the extracellular fluid. It means translocation of water across the cell membrane. Serum sodium falls about 1.6 milliequivalent per liter for every 100 milligram per deciliter rise in serum glucose above normal. The third case is a 70 years old female presented with generalized weakness. She was started in hydrochlorothiazide, it is a thiazide diuretics, 1 week ago for treatment of hypertension. The patient appeared hypovolemic on physical examination. Blood pressure 110 over 60 mm mercury, heart rate 95 beat per minute, serum sodium 125 milliequivalent per liter, serum creatinine 0.7 mg per deciliter, plasma osmolality 260 millismol per kg, urine osmolality 500 millismol per kg, urine sodium is 90 milliequivalent per liter. So this is an old female with a generalized weakness, started with thiazide diuretics. She was hypovolemic. Look at serum sodium. Serum sodium is 125, so she has hyponatremia. Look at plasma osmolality. It is 260, so it is hypoosmolarity. So hyponatremia with hypoosmolarity, so it is a case of true hyponatremia. True hyponatremia. Let's look for urine sodium and urine osmolarity. Urine sodium is high, more than normal, 90 milliequivalent per liter. So it is a case of renal fluid loss, renal sodium loss. So to approach a case of true hyponatremia, we check first the patient volume status. Hypotonic hyponatremia or true hyponatremia may be hypovolemic hyponatremia, euvolemic hyponatremia, or hypervolemic hyponatremia. Hypovolemic hyponatremia means a decrease in total body water with greater decrease in total body sodium. Euvolemic hyponatremia means normal total body sodium with increase in total body water, so it is a pure water excess. Hypervolemic hyponatremia, it is increase in total body sodium with greater increase in total body water. Hypovolemic hyponatremia may be due to extrarenal fluid loss as vomiting, diarrhea, sequestration of fluid in the third space. Typically هنا اليورين صوديوم بيبقى less than 20 milliequivalent per liter because the kidney function is normal and the kidney conserve to the lost sodium and fluid by increasing sodium reabsorption, so the urinary sodium is low. The second cause is renal fluid loss due to mineralocorticoid deficiency, thiazide diuretics, as in our patient. Osmotic diuretic salt was losing nephropathy and the urinary sodium is high, like in our patient. So our patient is thiazide induced hypovolemic hyponatremia. The fourth case is a 50 years old female with breast cancer. Was admitted to hospital for treatment of infected mastectomy wound. She has no other past medical history and not taking any medications. Her only complaint are pain and nausea. Serum sodium is 125 milliequivalent per liter. Plasma osmolality is 250 milliosmol per kg. Urine osmolality is 616 milliosmol per kg. Urine sodium 60 milliequivalent per liter, and the patient appeared euvolemic on physical examination. Here the patient is cancer patient. No history of any medications. The serum sodium is low, so the patient is hyponatremic. The plasma osmolarity is also low, so the patient has a true hyponatremia. Here the urinary osmolarity is high relative to the plasma osmolarity, and the urinary sodium is high, and the patient is euvolemic. So it is the most probably it is SIADA syndrome of inappropriate antidiuretic hormone secretion. The patient is euvolemic, true hyponatremic, high plasma, high urinary osmolarity, and high urinary sodium. The fifth case is a 65 years old female presented with acute decompensation of congestive heart failure. The patient appeared hypervolemic in physical examination. Serum sodium is 120 milliequivalent per liter. Serum creatinine 0.8 milligram per deciliter. Plasma osmolality is 255 milliosmol per kg. Urine osmolality is 580 milliosmol per kg. Urine sodium is less than 10 milliequivalent per liter. This case present old female with decompensated heart failure, and the patient is hypervolemic. If we look at the serum sodium, it is hyponatremic, and if we look at the plasma osmolality, it is also hypoosmotic hyponatremia, or true hyponatremia. So it is a case of true hyponatremia in a hypervolemic patient. The urine osmolality is high, and the urine sodium is less than 10 milliequivalent per liter. So what is caused hypervolemic hyponatremia? Maybe due to heart failure, as in our case, decompensated heart failure. Maybe due to cirrhosis or nephrotic syndrome. The urine sodium typically less than 10 milliequivalent per liter, because the kidney function is normal, and the kidney conserve sodium by increasing sodium reabsorption. So our case is hypervolemic hyponatremia due to decompensated heart failure. Let's collect the symptoms and signs of hyponatremia. Hyponatremia present mainly with CNS dysfunction, a change in the mental status. Extracellular volume may be presented by volume depletion or volume overload or euvolemia, and the symptoms more severe in older chronically ill patients, and more severe with faster onset hyponatremia. Diagnosis, as we tell you, first to exclusion of translocational and pseudohyponatremia, as we do in our cases. Second, to identify the cause of true hyponatremia from the history, if there is obvious vomiting, diarrhea, renal disease, compulsive water ingestion. And check the volume status. The patient may be overtly hypovolemic or overtly hypervolemic or euvolemic patient. The euvolemic patient require further testing to identify the cause. The lab test includes serum and urine electrolyte and osmolality. Serum osmolarity, as we said, calculated by this equation. Urine osmolarity, the normal urine osmolarity in 24 hours is 500 to 800 milliosmol per kg. Random urine osmolarity between 300 and 900 milliosmol per kg. 12 hours of fluid restriction, the urine osmolality should exceed 850 milliosmol per kg. Sometimes we need urinary sodium, as in patient of SIADA, urinary sodium typically more than 30 millimole per liter. In patient with hypovolemia, to differentiate between extrarenal causes and renal causes of fluid loss. In extrarenal fluid loss, urinary sodium less than 20 millimole per liter. In renal fluid loss, urinary sodium will be more than 20 millimole per liter. Check other electrolytes if there is hyperkalemia together with hyponatremia. This suggests adrenal insufficiency. Also, thyroid and adrenal function should be done, especially in euvolemic patient. What about the treatment? So serum sodium shouldn't be increased by more than 8 milliequivalent per liter over the first 24 hours. Sodium should be corrected not faster than 0.5 milliequivalent per liter per hour, except during the first few hours of treatment of severe hyponatremia. Rapid correction of hyponatremia risk osmotic demyelination syndrome. Next, we treat according to the volume status of the patient. If the patient is hypovolemic, we give normal saline, and we may need to restrict free water. In hypervolemic patient, water restriction, loop diuretics plus normal saline, or hemofiltration plus normal saline. Occasionally, a vasopressin antagonist may be needed. In euvolemic patient, treat the cause if there is hypothyroidism or Addison. Sayada need severe water restriction, and may need loop diuretics with normal saline. Now we will talk about hypernatremia. Hypernatremia is a serum sodium more than 148 milliequivalent per liter. Hypernatremia reflects the deficit of total body water relative to total body sodium, and it involves impaired serous center or limited access to water. Hypernatremia also considered with the volume status of the patient, and they can be divided into hypovolemic, euvolemic, and hypervolemic hypernatremia. Hypovolemic hypernatremia, there is a loss of sodium and greater loss of water, mainly due to renal loss, as in diuretics, commonly with loop diuretics, maybe osmotic diuretics, and also in patients with renal disease. Euvolemic hypernatremia, there is a decrease in total body water, but with normal total body sodium. So there is a pure water deficit, as occurring in diabetes insipidus due to deficiency of antidiuretic hormone or resistant to the actions of antidiuretic hormone. Extrarenal loss of water is in excessive sweating, as sweat is hypotonic. Primary hypodipsia or primary adipsia, occurring in children or chronically ill patient with lesions in the brain center. Or the patient may be hypervolemic hypernatremic as in excess administration of hypertonic sodium bicarb or hypertonic saline. Symptoms and the signs of hypernatremia: clot cyst. The absence of cyst suggests impaired cyst mechanism. Also, the patient commonly presented with CNS dysfunction due to brain cell shrinkage. The patient may be presented with confusions, neuromuscular excitability, hyperreflexia, seizures, or coma. Diagnosis of hypernatremia depends on the clinical and measuring serum sodium, assessment of urine volume and osmolality. If there is polyuria and low urine osmolality, the patient may be diabetes insipidus. A water deprivation test is occasionally used to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. Treatment: replacement of the intravascular volume and free water is the main goal of treatment. This replacement either by oral hydration or intravenous hydration in severe cases. Hypernatremia that occurred acutely in the last 24 hours should be corrected over the next 24 hours. Hypernatremia that is chronic or of unknown duration should be corrected over 48 hours. The serum osmolality should be lowered at a rate of no faster than 0.5 milliosmol per liter per hour to avoid cerebral edema. Also, we treat according to the volume status. If the patient is hypovolemic and hypernatremic, we can use half saline or combination of half saline with dextrose 5%. If the patient is euvolemic, we can use either dextrose 5% or half saline. If the patient is hypervolemic, we can't use saline. Here we prefer to use dextrose 5% with loop diuretics, and avoid to rapid infusions of dextrose because it is can lead to osmotic diuresis and aggravate hypernatremia. So let's discuss our case. Our case is a 68 years old male nursing home resident who brought to the emergency department for altered mental status since early morning. The patient had been experiencing poor oral intake and had been noted to be withdrawn from social activities over the past few days. His medical history include hypertension, hyperlipidemia, osteoarthritis, and dementia. His medication include amlodipine, simvastatin, and multivitamins. Patient was cachectic, had dry mucous membrane, and confused. Serum sodium 167, serum potassium 4 millimole per liter, serum chloride 125 millimole per liter, serum creatinine 1.8 milligram per deciliter. CT of the head showed no acute infarction, masses, or hemorrhage, as well as no chronic microvascular changes. So how would you manage this case? This case presents a common scenario. It is an old patient, nursing home resident, poor oral intake, admitted with altered level of consciousness due to poor eating and response to fluid. And this here the hypernatremia is due to poor oral intake and decreased water intake, decreased access to water in this old nursing home resident patient. And the hypernatremia in this patient should be managed cautiously in this case, and frequently monitoring level should be performed to prevent rapid correction and brain edema. Thank you.